So, progesterone plays a very, very significant role, of course, in support supporting the health and the recovery of breast cancer survivors. And to give this insightful session, we have Dr. Vivek Kadambi with us over here. Let me bring Dr. Vivek Kadambi on stage, please. Give me a minute. Dr. Kadambi, good morning once again. We saw you in the
Good
morning.
morning.
We are happy to have your session today, which is going to be definitely insightful. Just to add on, dear participants, Dr. Kadambi is the founder of Bella Sante, the Institute for Functional Medicine, and Dr. Kadambi brings over 30 years of experience in and expertise in the bioidentical hormone replacement therapy. Because I could see some questions on BHRT, and I'm pretty sure people would be very, very interested to learn about this topic. Dr. Kadambi is a leader in the field of hormone optimization and has worked extensively in the prevention of metabolic disorders, age related diseases, and cancer as well. So, he will be sharing his valuable insights on progesterone in breast cancer survivors. So, welcome to the conference once again, Dr. Kadambi. The stage is all yours.
Thank you, Amarjit. And I'm always more comfortable. I'm always comfortable when I'm on stage. Amarjit, you're going to be my partner in crime. So you will have to do the
Sure.
presentations for me.
Sure.
For the simple reason I like to see the audience when I'm presenting. And when I have my presentation, I can't do that. Second thing is I'm going to put my hat on because that cuts away the light on my glare from my glasses.
All
And of
right.
course, I think it makes me look smarter too.
Oh, it does.
Uh,
I was already saying that Zoom is a
yeah.
blessing for us, so we can
You
put
must,
any filter.
yeah, exactly. You must teach me how to do those filters, you know. So we'll figure this out. Okay. Now let me dive in
Just give me a
to,
minute. I'm just
yeah, sure.
opening up the presentation. All right.
Right.
Just give me
So while you're opening up, glad to see Mahesh here because Mahesh is literally, uh, I would say, my right hand when it comes to managing hormones because I don't know anything beyond the hormones, and Mahesh is the one who manages. And we do a lot of infertility cases management myself. And when a question is asked to me, what's the success rate in infertility? My answer is with Mahesh or without Mahesh. So the statistics are totally different. All right. So there you go. Progesterone replacement therapy in breast cancer survivors. Survivors is a key. And it's important that at the outset, let me declare my financial interests as I always do in any other conference. I am also running a compounding pharmacy that supplies the products all over India and, of course, for some abroad as well. So having put that aside, let me go to the next slide. Yes. So first, let's start with understanding progesterones. We need to understand progesterones in the in its entirety before we go into its uses. So facts relating to progesterone and breast cancer, let's take the undisputed facts first. Progesterone does not cause breast cancer. Progesterone is protective and prevents breast cancer. There are enough articles on that. Progesterone positive or progesterone receptor positive breast cancer indicate good prognosis. And progesterone replacement therapy has a potential for improved quality of life. So if you keep all this in mind, it's very surprising to note that despite the above progesterone replacement therapy in breast cancers, survivors is not practiced. People often practice BHRT, they give progesterones, but when it comes to somebody who has breast cancer, I don't see my timer on. So does that mean I've got unlimited time? That's nice. Okay, so despite the
We are
above
switching
facts,
it on. That's a nice one, though.
okay, anyway, I'll take advantage of that. Okay, so breast cancer survivors is not practiced, which is very unusual when you see all these benefits. So, well, I don't see it, but if any one of you feels that we should not give progesterone or hormones for cancer, breast cancers, ovarian cancers, or prostate cancer, any cancer, then you can put that reaction. There's a reaction that shows the face like this, you know. So I know that if that many of you do think that we should not be giving, or that's the impression you have. Oh, your heart means you agree with me? I don't know. Okay. Well, anyway, a lot of people, and especially, yeah, that's it. Okay. So this is what I'm looking at, the reaction when I suggest any kind of a hormone replacement when people are referred to me for management of cancers, especially when they already have existing cancer. And I suggest hormones, and of course, the oncologist hits the roof, and the whole family thinks, that something is wrong with me, and we move on. Okay, next. Uh, Next slide, please, Amarjit. Um, Okay, so it's as Amarjit once, I mean, she commented that she was so thrilled that Mahesh has understood, or a male has understood the hormone, the menstrual cycle. I think it's very important. I wish I had known this when I was younger. And this is the advice I would give to all you young guys out there, young males out there, that if you want to understand women, people come to me and say, I don't understand women. I don't understand women. I said, look, just understand the menstrual cycle, be empathetic towards the menstrual cycle, and mark the dates that you stay away, and you're fine. So this is the best way. So first, understand menstrual cycle. Now, unfortunately, the menstrual cycle has been also projected not in a very positive way, or not positive, in incorrect way. So if you see the graph, let me first start off with a very, very important note that estrogen dominance really means progesterone deficiency. I'm not discounting the fact that Mahesh had talked about the xenoestrogens and the estrogens you get. Yes, now there is a reason why you can get estrogen excess too. But let us put that aside. In most cases, when we talk about estrogen dominance in PCOS or in any age group, it's to do with progesterone deficiency. So if you want to fix estrogen dominance, focus on improving the progesterones. In younger patients, you can improve the endogenous progesterones, and in older patients, you can replace it by bioidentical or natural progesterones. I will talk about roots and all later, but having said that, look at the menstrual cycle. If you look at the menstrual cycle and look at these pictures, they look like estrogen and progesterones are almost equal. But if you look around, there's no mention of the units. So it's not really equal. Progesterones are measured in nanograms and estrogens in picograms. There are three zeros separating them, three zeros, 1,000 units. So if you try to bring them to scale, and if you look at during menstrual cycle, the percentage increase, now it looks much different. And this is the perspective I want you to have on progesterone. Progesterone levels vary by 1,200% in every menstrual cycle, and 200% in the estrogens vary during the menstrual cycle. So if you try to put the graph, it looks more like that. Uh, Also, if I would, and this is also percentage. Now, if you put it in absolute terms, look at what happens. How I would say normally progesterone is so dominant and in the second half of the cycle, and of course during pregnancy. So if you look at the estradiol level, it's hardly peeping up there. That little blue line, if you want to put, have a proportionate graph, and you have in the luteal phase and the peak phase progesterones of say 15 or 16 in that range, and you would see that it's fairly higher than what is normally shown in most diagrams. And if you take pregnancy, I don't have enough space on my slide to even show the kind of level it goes up. So when you understand that, one of the things you will understand is the body can take, and in fact loves a lot of progesterone. Progesterone, you don't have to worry about toxicity or excess of progesterone as you have to be worried about estrogens. But it's important to understand that a progesterone is so high, and suddenly in perimenopause or in that period, you will find progesterone not falling gradually but crashing to zero. No ovulation, no progesterone. That's a dictum. If you ovulate, you get progesterone. If you don't ovulate, no progesterone. That's about it. Next slide, please. So if you understand this, next slide. Yeah. Okay. So if you understand this, the estrogen dominance is treated by promoting ovulation in younger people, or by the progesterone replacement therapy, and of course reducing the exogenous estrogen impact, and not by blocking estrogens. You will understand what we are doing now in management of these cancers is wrong. Anyway, we do know estrogen dominance causes fibrocystic disease of the breast cancers, uterine cancers, ovarian cancer, uterine fibroids. All that is known. So what happens in perimenopause? If you look at the graph, the level of progesterone levels are still higher than estrogens in absolute terms. It's only that in the numbers, because you have picograms and nanograms, they seem to be low. So your goal should be, after you replace with bioidentical replacement therapy, progesterone, you should try and achieve a reasonable level, somewhere, of a 30-year-old or 25-year-old, at least halfway there. And this is what you should be aiming at in terms of the levels. However, Mahesh did mention that don't get carried away with lab levels. Treat the patient symptoms and don't focus so much on lab levels. However, progesterones are fairly reliable. If you are looking at lab levels of progesterone, it's very reliable. Estradiol and estrogens, not very reliable, so it can be very confusing. But as a clinician, you'll be able to manage that. Next slide, please, Amarjit. All right. So let's take now those who attend my Tuesday morning reboot sessions, they know that my habit is always to put what's evidence. It's called, as Preeti loves my saying, "Tera hi tota kehta hai." So somebody asked me, if you have to defend yourself, say, "Bhaiya, tera hi tota kehta hai." This just medical
Thank you,
journals.
Dr. Vivek, for putting that in our minds.
All right, so that's and always brings a giggle on and her hearty laugh, Preeti's hearty laugh. I love that. In defense of yeah, I can see that that laugh is coming. In defense of progesterone, there was a review. So let's take that this review said that three studies involving 86,881 postmenopausal women reported that use of natural progesterone was associated with a significant lower risk of breast cancer compared with the synthetic. So there have been head-on studies between bioidentical and non-bioidentical synthetic. There are large hundreds of studies, at least, if not more. Now, this study is interesting. It took controls that did not receive hormone therapy, then those that received estrogens alone, probably estradiol, and those used with combination with natural progesterone, and those in combination with synthetic progesterones. And that's where the understanding of all this, when somebody talks about generalization about hormones and its impact on cancers, you have to specify what hormone are you talking about, synthetic, your bioidentical, non-bioidentical, and makes all the difference there. Low levels of serum progesterone have been associated with significantly higher risk of breast cancers in premenopausal women. There you go. Lower rates of uterine. Now, this is interesting. My topic is breast cancer, but let me tell you, progesterone is overall protective. And therefore, I think that's why nature has increased, given such high levels in pregnancy. Progesterone gets its name from progestational hormone. So it's basically, it's there to protect, not just sustain the pregnancy, a lot of protection. And I can see every day, every time research is throwing up newer and newer things about progesterone. Low rates of uterine, colonic cancer, and may be used to treat other diseases, also preventing cardiovascular diseases and treating neurodegenerative disorders. So there you go. Progesterone is not just a hormone that is to do with reproduction. There's a lot more. Next, please. Here you go. Yes. So here again, could transdermal estradiol plus progesterone be safe for postmenopausal HRT? A review. Again, review articles tell us, yes, the risk of developing deep vein thrombosis or pulmonary embolism is negligible when you use transdermal, the root transdermal estradiol and progesterone. And therefore, it specifically says non-oral administered estrogens minimizing the hepatic induction of clotting factors. Natural progesterone displays a favorable action in the vessels and on the brain, and this is not so true of progestins or synthetics. Natural progesterone with estrogen confers less or even no risk of breast cancer as opposed to synthetics. The choice transdermal route of administration of estrogens and the use of natural progesterone might offer significant benefits. Next, please. Yes. Okay, progesterone mediates apoptosis in beta HCG responsive tumor cells. And now, while we're talking about breast cancer, let me tell you that I'll just summarize this entire article. Progesterone limits the tumor-producing effects of the beta subunit of HCG via non-nuclear receptors. What does it mean? That in progesterone protects against lung adenocarcinomas, colon adenocarcinomas, glioblastomas, and therefore it can be used as a general overall protection on just not just breast cancers. We'll come to breast cancers, of course, but I wanted to show you that it's much more than that. Next, please. Yeah. Okay. So I don't know what's happened here. It's a lot of kishpich here. Never mind. I'll read here. Uh, the whenever we talk about breast cancers, people talk about ER/PR or the receptors and positive. And they say, oh, when the ER/PR positive, they have the best prognosis. Now, I want you to understand and see through read between the lines and see through what the pharmaceutical companies are trying to push and actually causing more harm. Okay. Now, positive. When you see when the PR is positive, it seems to give a good prognosis. Let me not get into it. I'm just giving a generalization that when we see PR positive, prognosis seems to be good. Whether ER is positive or negative, and of course we have HER2 also, but we'll keep that for later. And then they say response to hormone therapy. Please don't get misled by this word hormone therapy. It is anti-hormone therapy. When they say hormone therapy, it is using selective estrogen receptor modulator, aromatase inhibitors, it is blocking all the way. And then if you see the progesterone positive breast cancers, carcinoma of breast was 60% positive and approximately 2/3 of the case. So basically what it's trying to say is that if you have progesterone receptor positive, the prognosis is good. But what the pharma company will tell you is if it's progesterone receptor positive, our drugs will work better. Now that's wrong. If it is positive, the overall prognosis is good. In fact, it means progesterone will work better. Why? Because unlike what people believe, when you have estrogen positive and you give estrogens, it will stimulate, but progesterone will actually control or inhibit the growth of the cancer. So it's quite the opposite, and it's not stimulatory. Next, please. So what is that? Where does that bring you? So now let's say that, and we know why progesterone, selective progesterone receptor modulator did not work. But let's say that this is what they were thinking. Okay, let's block progesterone receptors. How do we block it? Put something like similar to progesterone, block the receptors, and the progesterones can act. And let's call it selective, because people will wonder what will happen if I block progesterone in other parts. So let's call it selective progesterone. And they tried. Now it became very confusing. And if you go online and try to look at it, it says that this progesterone blockade, what we use, this works as an antagonist as well as an agonist. So my first thing is, Mahesh, where are you? I want Mahesh to make sense out of this. That you're giving something and you're trying to, it's very confusing. Then you say that transcription activation happens and there is no transcription activation happens. So why are you trying to block progesterone and come out a drug and then show this beautiful figure and say that you can be agonistic as well as antagonistic? Now it doesn't make sense to me. If it makes sense to any of you, please go ahead. Next, please. Go ahead. Yeah. Yes. So, of course, sure enough, it's not surprising there was liver toxicity and there was so much of toxicity that they just stopped the trials and said, chalo, forget about progesterone inhibitors, jo via billions of dollars, we are not going to waste our time. Let's attack the estrogens. Next, please. All right. So let's attack the estrogens. So then progesterone receptor modulates. So while that was happening, the people who are doing the research voices were not strong, but saying, look, bhaiya, progesterone receptor modulates. So give progesterones. If you give progesterones, if you have good progesterones, it will modulate the action of the estrogen receptor alpha in breast cancers. Again, tera hi tota kehta hai. What does it say? Remember, read my lips. Progesterone inhibited. If I was on a soap, it would be 3 times, inhibited. Inhibited estrogen mediated growth. Inhibited is a key, and cells, line, xenografts, etc. So, in other words, progesterone is good. It is inhibiting. Chalo, I'll give you more evidence. Next, please. It's a rheostat. It modulates. Okay, so here's what, if I were a drug company, I'll try to project the first part and not show you the second part. The first part says, the question is, why do this double positive, ER/PR positive do work better? I said, look, because our drugs work better. We use estrogen is stimulating, and if you block that estrogen, it will not happen. But moment you have progesterone in, it puts a brake on the estrogen fueled growth and division of breast cancer cells. So this is the part they wouldn't want you to know, that yes, we'll block progesterones, but the easiest solution was to give the block estrogen. So easiest solution is give the progesterones. No, we're not going to do that, because then we don't have a drug, because our progesterone blocking drug is not working. We are going to go hammer and tongs after the estrogens. And remember, when you are trying to kill the cancer cells, you want to protect the existing cells. So this typically happens in war. You're trying to go hammer and tongs against the cancer cells, and you're killing all the normal cells, which they're doing their job, and you're still trying to kill them. So you need the protection to continue for the normal cells also. Chalo, let's work on at least that. Next, please. Okay. This interesting study from University of Adelaide, adding progesterone at the same time as estrogen slowed down the rate of the tumors. They didn't say same time as estrogen blockage. Estrogens with progesterones. So when we work together, I can see Mahesh smiling year to year, because this is what people don't get it. If you give estrogens and then say, yes, look what's happening to the growth of cells. Yes, but if you give estrogens and progesterones, is different. Or forget the estrogens. Body will have enough estrogens. Give just progesterones. And interestingly, with tamoxifen and progesterone, the tumors grow even slowly. So where is the problem? Is the problem with progesterone, estrogens, or with tamoxifen? I think this is important. And at the end of this day, I will bring out all those who have family or who out there I know on tamoxifen. Please understand, there's a lot of resistance to not taking tamoxifen, but your body will scream. Yeah, next, please. Go ahead. You're nice, intuitive, Amarjit. You're very intuitive. The next one. Okay. So let me put it in diagrammatic form. Tamoxifen. So tamoxifen goes and blocks those receptors and doesn't allow the estradiol to affect. Okay, fair enough. But you know what I have observed? Unless the oophorectomy was done, all those cases, if you measure the estradiol level, you will see the estradiol level rising, because the body is going to compensate, trying to throw estradiol. And believe me, the levels have gone as high as 300. 300 when with tamoxifen. What is the answer? Give more tamoxifen. Because, let's fight the body or get rid of the ovaries. Let's do a oophorectomy. I mean, is that casual? Chalo, usko nikalo. Then also let us block testosterone. Oh, this testosterone is creating this problem because it is getting converted to estrogen. So let's use aromatase inhibitors and that estrogen, we'll treat that estrogen less and let's block that estrogen. So this is how it goes. Next. Yes. So now let me tell you about tamoxifen and pay attention to this. I've often told this to my students. Everybody says tamoxifen is wonderful. You should take tamoxifen, tamoxifen, tamoxifen. Okay. Now, there's an experiment here that you expose tamoxifen to that same dose equivalent of that you would give a human. And in the first 48 hours, it killed more than 75% of oligodendrotic type 2 astrocytes. That means these neural cells. And therefore, it says that tamoxifen is toxic to the cells of the brain and central nervous system, producing mental fogginess similar to chemo brain. This is what the subli says. Tera hi tota kehta hai. Produces troubling effects in the subset of large number of people who take it. So what happens is they say large number of people. Large number is large number. So now if you ask every patient on tamoxifen, they say, I feel awful, I feel brain fog, but I've been told that I must take this, otherwise cancer will recur. So every patient, not with, there's no exception. However, tamoxifen is given because they fear that, cancer will come. Next, please. Next, please. There you go. All right. So it causes mental fogginess. It's toxic to the brain. It causes depression, debilitating events. It causes everything. Next slide, please. All right. Patients are not always taken seriously. And actually, this is an organic syndrome, and short-term memory loss, mental cloudiness, and trouble concentrating is important. Don't ignore it. Next, please. Go ahead. Yes. Now, the neuropsychiatric effects of tamoxifen has been produced. So now comes another crazy thing. It's supposed to be selective, but it is affecting cognition, mood, and then they says no, it is crossing the blood-brain barrier and it is causing central anti-estrogenic activity. So, oh boy, that means it's not selective. So by just calling myself Ashok doesn't mean he's free of grief. By me calling myself Vivek, unless I work hard towards getting Vivek Buddhi, I don't become Vivek. So calling something selective doesn't make it selective. So one thing for sure, Baya, it is not selective. It is anti-estrogenic. Next, please. Okay, go on. Okay, now look at this. While up to 1/3, now somebody tells you, let me tell you something about the tamoxifen. 1/3 of patients are resistant to tamoxifen in the beginning of the treatment. Acha, chalo, by 2/3 is there, but he says afterwards, majority of the patients who initially respond to tamoxifen also become resistant. So we know why, because the body will try to do this, whatever, becomes resistant. Chalo, that means majority of them become resistant, and you are now asking me to take tamoxifen. So what do I do? No, take it for some time. How much can I take it for 1 year? 1 year we'll see. I think you should take for 5 to 7 years. That is the way in which it is for 5 to 7 years. You need to take it. Next, please. Emerging. Next. All right. Now comes the moment which I call the WTF moment. What this study, I got this expression that the emoticon says, it enhances and promotes metastasis in ER positive alpha 36. What? It enhances and promotes metastasis. I thought the idea was to prevent metastasis, to prevent the growth. Yeah, but in those. But then I researched and I found that ER alpha 36, which we don't test for, we always say positive, is widely expressed in human breast cancer specimens. So I said, well, then in that case, it doesn't seem to be so. If the whole idea was to prevent breast cancer and metastasis, it's going in the opposite direction. How about this? Let me measure. Is there any way I can measure ER alpha 36? Mahesh, help me out. If there is some way I can do it, then I'll say at least in those cases don't give it. Of course, I would not give in any case. Next, please. There we go. So let me go through this tamoxifen thing. Okay, now triple negative breast cancers. The oncologist says, oh, triple negative, nothing can be done. Don't worry, you can do whatever you want. No. There is one thing about triple negative. 10 to 20% of breast cancers are triple negative. You can't ignore them. They tend to grow and spread more quickly. They're considered more aggressive. Treatment is challenging, and therefore the hormone treatment is targeted. By the way, when they came to know that it's no longer selective, and they said, "Bhaiya, I got a call, boss. Now we can't use tamoxifen because it is causing neuro symptoms. I think billions of dollars are going. Let's abandon this drug." Boss says, "No, what is it causing? It's causing some effect in the brain. Let us now find a new indication," and they have promoting it for bipolar patients. Let us use it for psychiatric disorders. So it's just indication have changed, Don't throw the meds out. I forgot to mention that. Next one. So what do? This is where progesterone is so beautiful. It has nuclear receptors, it has membrane receptors. Now, then the progesterone suppresses the growth and migration in case of triple negative breast cancers because MPR alpha plus. So they have membrane PR alpha receptors which actually work. So progesterone, nature has given progesterone all these unlimited protection properties of protection that it suppresses TNCV growth. So even in those which are progesterone negative, even in those which are triple negative, progesterone works. Next, please. All right. Now, drug companies say, chalo, tamoxifen is blocking estrogen. So person is having hot flushes. The patient is having depression because of no estrogens, or maybe because they think they have cancer. There's depression. Okay, don't know. Psychiatrists, let them give SSRI. The SSRI inhibits this enzyme CPY2D6, and that which supposed to help tamoxifen doesn't. What's the answer? Give more tamoxifen. Let's give them more tamoxifen. Cause more depression. So add more and more drugs to counteract something that you have introduced yourself, and rather than take it away. Next, please. Yeah. I don't know why this bolt comes finally, but anyway, it's a 41-year-old patient, and this particular patient, maybe I should not have used that bold font. It's not doing very good. Anyway, so this patient came in 2021. I remember this very, very clearly, and came with oophorectomy and everything done, mastectomy, oophorectomy, chemotherapy, and then came to me because of the thyroid. Now, remember, one hormone you're trying to interfere with, other hormone wakes up. Said a TSH of 10.7, and what do you do? And while doing that, spoke to the patient, talked to them as I would talk, and she said, yes, I'm convinced, doctor. I can't stop tamoxifen. I don't have the guts. My oncologist will kill me. But I'll take your tamoxifen along with I'll take your progesterone along with tamoxifen. I said, great, do that and suffer. She said, anyway, and after 1 year, I'm planning to stop. She goes back to the doctor and says, and then I think I wish I had this quote over here. And if I open my presentation, her words are very, very nice. 3 years of tamoxifen, and she tells me and sends me a message, I'm tired of being tired. Those are her words. I'm tired of being tired. And she was a fitness freak. She's in fact now gone recently, a couple of months ago, and got her breast reconstruction also done. So, very, very much aware and very, very dynamic lady, and has to suffer because she finally went to her 3 years and said, can I stop tamoxifen? Now he said, no, I think you should take at least for 5 to 7 years. Now, remember this, choice is the patient's. Don't try to push the patient in any direction. But look at the progesterone level, 0.47. Estradiol, non-existent. There's no estradiol, 15, whatever. And of course, they're also done oophorectomy. Now, remember, if she had not done oophorectomy, this estradiol levels would have been very high because body will still try to protect. 300 I have seen for those without oophorectomy. Anyway, next one, please. Remember, I have given her vitamin D, I've given her the B12, I've given her curcumin, we've given melatonin, all the other things that we need to do in functional medicine. But important is on that foundation, we give the progesterone. Now, look at the now levels beautifully, 9.6, 156. So very good levels of progesterones. Estrogen is still trying to go up. It's at least come from less than, it's coming to 24 or somewhere there. So body is trying to still protect her. And of course, other parameters are all up to the mark. But look at her CTX, her bone, she is losing so much of bone, 1,206. So CTX is a very useful test for all of you doing bone turnover. And it needs a bit more interpretation, so don't go by what, but this is very high. I'm waiting when she stopped the tamoxifen, I'll come back and present to you how beautifully her bone recovers. Next, please. Next, please. Yeah. There you go. Oh, right on time. Amarjit,
That is
you
so
might...
perfect. The superwoman emerges there with the right amount of progesterone has come in.
Yeah. Actually, I must tell you, what is her name? Renuka, remember my first presentation was with me, like Superman coming there. I showed it to my wife, also a doctor. She said, I think you should put Superwoman there. You can't have a man. I said, right, and I've changed that. So Superwoman comes, prevents breast cancer, prevents against recurrence, metastasis. So it's the message here is natural progesterones, transdermal, sublingual. This patient was taking sublingual route, 50 milligrams of sublingual. People like Mahesh and others, they know. Don't talk about rule. Just do what it takes. Protect your liver. Do what it takes to get to a decent level because progesterone levels are there, and it will always protect. You can never go wrong with natural progesterone. You can never go wrong. Okay, there. Open to questions.
Sure, just give me a minute.
There you go.
Undoubtedly, a wonderful, wonderful presentation there. A mix of
So
both ways,
Amarjit,
heart and
Amarjit,
brain.
this
Yeah.
is how I end my presentation. Thank you. Go.
All right. That's lovely. That's a clean slate. Absolutely. All right.
Absolutely.
Wonderfully presented, undoubtedly touched a lot of hearts as well. So many insightful things that I could see. No doubt मेरा भी तोता बोल रहा था कि ये क्यों मैंने टाइमर लगा रखा है, but at least वो टाइमर सही टाइम पे बज गया. That is correct.
Oh,
All right.
fantastic.
So I am just going to look into the questions. All right. So Dr. Ashok Kadambi, I'm undergoing ADT for 3 years after radiation therapy for prostate cancer.
Hmm.
Daily on empty stomach. There is a mention of the medicines. I think you would like to take it directly. Abiraterone, which is 1000 mg, and after
Embarrassing.
breakfast, there is prednisolone, that is 5 mg. Lupride injections once in 3 months. My PSA
Okay.
is,
So I got that. I don't have to
yeah,
go through the details. And of course,
yeah,
it was addressed to Ashok Kadambi, who probably will be in sleep now because his US time, it's quite late. He did
I
address the
missed it.
testosterone. Never
Okay.
mind. But I can tell you that, yes, there was a mention of this Abitron, this thing with progesterone also. As is the urologists are all for it. They'll say, get off it, take it off. Your oncologist will never agree. So you have to have a personal consult with well, with me or with Dr. Ashok also, if you wish. And it has to be handled in the way. Finally, it's your decision. When people say, I'm going to get off tamoxifen, I don't want them saying that Dr. Kadambi told me to go off tamoxifen. I'm going to put the facts before you
Yeah.
and tell you that this is what it is. This is what literature says. Now, once you choose, then I'll be with you. But if you are not choosing, this is another important lesson for all my students out there, that do not try to coerce anybody or convince anybody. If they are not convinced, let them be. Just let them be. But yes, I've seen the prescription. This is a very standard one. I think that I will be able to fix it if you come. But you should be ready to take testosterone if you're for prostate cancer, and then be there. Anything else?
Thank you for answering that. And I'm just going to quickly take a common question which I could see. What are the natural sources of progesterone?
So there are natural. In fact, when we get progesterone, what we use in compounding is extracted from either the wild yam or from soya. Soya nobody uses nowadays. It's from wild yam, but you can't get it by eating wild yam unless if you have an expert there in Mahesh. So I always turn to him. I say, Mahesh, if there's any way I can get progesterone by any other method, I would. Estrogen's possible. Like Ashok said, you can take estradiol even orally. But there's unfortunately no way you can get it, which is a good thing, which means that you won't be getting any. There's nothing, no such thing as a xenoprogesterone. You have xenoestrogen. So you're entirely dependent upon, and there is no fat cells to give you progesterone. You're entirely
Yeah.
dependent upon your ovaries and that to our ovulation. And if not, it is, and therefore I think Ayurveda and other alternative medicine had something, because they would take these herbs which we don't know, perhaps they contain progesterone or components of so much, and they rubbed it with olivines and salt on the skin, and you got it transdermal. So transdermal seems to have been there for a long time. So with progesterone, there isn't. Testosterone also there isn't. Estradiol, yes, you have options.
Thank you for answering that so perfectly well. And just one more thing. मेरा तोता ये भी बोल रहा था कि महेश जयरमन का mention बहुत हुआ था. So I wanted to know whether Mahesh Jayaraman ji wants to come on stage and
Please.
answer.
Arey,
Uh,
he saves me from all these questions, because when they ask, somebody mentioned, I forgot one, there was something about something increasing the thing of progesterone. I said, Mahesh ko pucho, because wo mera tota hai. Mahesh,
Yeah, so
somebody said something, berry or something improves.
absolutely, sir. Very happy to help in any way possible. So, sir is absolutely right. Wild yam, unfortunately, doesn't get processed easily into progesterone in the human body. There is a further conversion that is needed. So, progesterone, any woman who wants to increase her progesterone, increasing ovulation by doing all the other right things, that's the way that you increase your progesterone. Otherwise, you need Dr. Kadambi and you need replacement.
If you don't meet me, you can meet one of my, other my students, if I call them, or my colleagues. I can see Kalpana is here. I saw Anjali Huda yesterday. Preeti. So you could meet any one of them. Doesn't matter.
No doubt, one of the who's of the industries have been called up in the IAFM conference. Thank you once again. And definitely, we are, I think, going a bit ahead of time. I know the participants are looking into it, but this is definitely engaging. And I'm pretty sure the Sunday is sizzling. Please let me know, participants, how is it going? I would love to see thumbs up, hearts, or whatever you want to send, or maybe that face which Dr. Kadambi was looking for. All right.
Anything.
So, with that, thank you once again, Dr. Kadambi.